what's your normal tidal volume? Just sitting right here in the room. Anyone want to gander a guess? It's okay. 350? Okay. What about mils a kg? How many mils a kg would you guys say? I hear 4s, I hear 5s. I like this. Okay. The answer, I'm glad you guys are going on the low end. The answer is 7 mils a kg. Okay? We've known this since about the 60s or 50s. The veterinarians have told us this. They did a bunch of studies, how they hooked up an orangutan to one of these machines, but they did, and they basically measured lung volumes by size. So we've known this for a very long time, and for the longest time, we, in the adult emergency world, have been ventilating people at 12 mils a kg. Okay, we're going to get into that. So really overinflating, because if 7's good, 12 is much better. So normal tidal volume is 7 mils a kg. This is one of the ones you got to memorize. 7 mils a kg, okay? So memorize that one. So for the longest time we were doing that. We were doing 10, 12, up until 2000, even a little bit after 2000. There was a big study called the ARDSNet, okay? This is one of the important seminal trials that happened in the, back when Y2K and everyone was buying toilet paper and stuff like that. This study happened and they were like, man, let's just see if we just did normal tidal volume ventilation. So they picked 6 to 8 mils a kg. You can ventilate everyone between 6 to 8 mils a kg, and compared to standard of care, which was 12 mils a kg. And guess what happened? Turns out that we were causing a lot of lung injury. Ventilators used to be seen as bad. You just went on a ventilator to kind of die. But now we're like, oh no, you can help someone recover through it by using normal lung physiology, normal lung volumes. So the reason I have a picture of a tasty pangolin, there's aphrodisiacs, all the way up to this guy right here, all of us are 7 mils a kg, all mammals, okay? So ARDSNet came out with this nice little chart. So remember that important 7 mils a kg? Instead of doing math, they gave you a way to calculate it because it's all by your height, your ideal body weight. So I'm a little fluffy. If you guys ventilate me based on my current body mass index or my weight, you're going to blow my lungs out probably, not do me good. But by my height, I'm only 5'10". So my question for you guys is, what the hell is going on here? Why would I have a bottle of great, this is like I drank it like last night or something like that, and a nasty bottle of water. I like Walmart, I'm sorry. A half a tennis court, and then what I consider the ideal male right there, Don Draper from Mad Men. Is that show too old now? No one knows who this guy is? Yeah, he's from St. Louis, isn't he? Yeah, I didn't know St. Louis made something this attractive. This is like, yeah. What the heck do all three of these things have in common?
You drink a bottle of water and play tennis, you look like him.
I wish. I tried it didn't work out. So, normal, what do you call it? We said about a 5 foot, he's about 5'10", okay? And it's about 70 kilos. We said, remember that? We calculated 70 kilos. So what's 70 times 7? 490. Is that close enough to that great value bottle of 500 mils right there? Okay, that's your normal tidal volume right there. That tennis court right there represents your total lung surface area. Your body can distribute that great value bottle of water across an entire tennis court and do it 15 times a minute. And it basically, that's the surface area content. It blows my mind. When that was designed, this blows my mind. The surface area of your lungs to distribute that volume. This is a medical student trying to actually squeeze. I made them go outside and squeegee, and it evaporated way before they finished squeegeeing. So, but your body does that 15 times a minute, 20 times a minute. When you're sick, it does it 30 times a minute. It blows my mind. I don't know why that's just fascinating to me. So, no lecture about lung physiology would be incomplete without this VQ stuff. Have you guys ever heard this before? One time maybe in paramedic school? You guys heard it before? So VQ, I don't know why it's Q, but V is ventilation, Q is cardiac output. It's probably something German, that's my guess. But total ventilation is about 5 liters a minute, okay? Total alveolar ventilation, not total ventilation, we're gonna get to that. Total alveolar, what makes it to my alveoli is about 5 liters a minute. My cardiac output, I have about 5 liters of blood in me right now. If you guys took an AR-15 to me and we tried it out and put me in a tub, you'd get about 5 liters out, okay? You circulate that in 1 whole minute, 5 liters a minute. So what goes into the lungs has to go through the lungs. In a normal scenario, all the way on the bottom left, you guys see that? The same amount of blood and air moves around together, and they mix. If you have a PE, what happens? You got maybe 2.5 liters of blood going through, but you got 5 liters of air. So you have more V than you have Q. That's not good. You want them to be the same. Or let's say you have asthma and your lungs are all tight and closed up. You have more Q, 5 liters of blood circulating, but there's no V. There's not much air. That creates a mismatch. That doesn't let you exchange CO2 and doesn't let you oxygenate. Did I lose anyone there? It's all basic? Okay. So I said a very key word, alveolar minute ventilation, because you guys are going to learn minute ventilation on these machines right now. There's an ASV mode that they want you to know, and it has minute ventilation on there, okay? So alveolar minute ventilation is different than what actual minute ventilation. Actual minute ventilation is my whole tidal volume, not just what gets to my alveoli. I still have a trachea. I have a mouth. You guys hear it. It's a very loud mouth. I have a big nose. All that stuff is dead space. There's no capillaries in there absorbing oxygen. Do you guys see that in there? There's no capillaries absorbing oxygen. So that's a big waste of space right there. But it's made there to filter out all the dust and the cigarette smoke and all the other stuff. It's made to filter that stuff out. It's not good enough for cigarette smoke, but it's good enough for most other things. So I only get 5 mils a kg. I told you guys 7 mils a kg, but I only get 5 really to my lungs. It doesn't matter, because on the ventilator, you guys are going to program 7, because that's what you're shoving in normally to people, okay? So 5 mils a kg, because if you did some math, you'll find out that that whole 5 liters is not actually accurate if you do some math. Let's play a game real quick. So 7 mils a kg. My, what do you call ideal body weight's what? 70, 490. So can we say 500 is my tidal volume? How many, what's an easy number? Let's pick anywhere between 12 and 20. 15, is that okay? What's 15 times 500? Or what's half of 15? 7.5 liters? Would you buy that? 7.5 liters or 7,500 mils? Okay, so 7,500 is not 5 liters, which I told you guys earlier. That extra 2.5 liters of air is dead space. So I just wanted to make that clear. The reason that's important for you guys is when you guys are hooking up all your little fancy devices, you're adding stuff to the stack, they call it. So the heat exchanger, the tube, everything you're adding, every time you add a little new, whatever Dr. Tan wants you guys to add onto their devices and some new suction catheter and some newfangled oxygen sensor, every little device adds dead space that you probably have to account for, okay? So be wary of that. This becomes important when you have COPDers and asthmatics and you need to blow off CO2. I one time had tubing this long because I was trying to do like some fancy thing and move patient around all this equipment. And then when we got to the hospital, CO2 was 90. And they were like, what the heck is going on? And he was just rebreathing all that dead space in there. So he wasn't able to ventilate off the stuff. So this is the reason I bring up alveolar versus actual minute ventilation. Here's what the equipment actually looks like. So look at some tidal volumes. So HME filters, it depends. You guys are SCAD, so you guys probably have a way more expensive, nice one. So it's got probably like 100 mils instead of 55 or 45, okay? So pay attention to all these little devices and all the dead space you're adding. So be cognizant of that. And that's important because you're basically taking away oxygenated air from the patient. You're not giving them the full breath that you want to give them. Questions? Is this confusing? Really easy? Why I wanted to bring this up right now is I want to go over a little bit of review. What goes into the heart should match the lungs. We got that down, right? Average tidal volume, we said, was 7 mils a kg. Average alveolar tidal volume is 5 mils a kg. There's 2 mils of dead space. So this is all review. Here's where it becomes important for your ASV ventilators, okay? Normal minute ventilation is 10% of your predicted body weight. So if I'm 70 kilos, what's a normal minute ventilation for my body? 7 liters a minute, okay? 7 liters a minute is a normal minute ventilation for me. So 10%, memorize that, 10% of your predicted body weight is your normal minute ventilation. Okay? So normal minute ventilation, I gave you guys a range because you could have a 5'0" petite person, or you can have Shaq. Shaq's probably way off the chart somewhere else, but is Shaq still relevant? Does people know who Shaq is? Okay, cool. Huh?
You just say Halra.
Who's Hollera?
He served IPD chief.
Oh, is he super tall? Okay. Would he be 8 liters a minute?
Probably more.
Really? Would he fit on a striker gurney? No. Legs dangling kind of thing? Okay, so yeah, he's up in the 8-liter range. Cool. So I want to bring you guys something back here. Do you see the stroke volume? There's some magic to that. It's 70, it's about your predicted body weight. So my body weight is 70 kilos, right? Well, I'm not 70 kilos, but supposedly, if I was, 70 kilos, 70 mils. Look at all these fans. God really made it easy for you guys. He was like, I knew the SCCAD medics were going to be working on this. I'm going to make this easy. So that's your stroke volume. That's how much blood is ejected out of your heart every single beat. So if you were a 60-kilo person, predicted body weight by your height, you're probably ejecting 60, okay? Now, athletes are different. They do not have to, they eject way more. So people that are fit and people that are not me can eject way more than that. They could be plus like 85 mils. It can be 90. I don't know what Lance Armstrong with one testicle was able to do, like 120 or something like that. So
his own blood or somebody else's blood?
Someone else's. The blood of virgins. Okay, so normal cardiac output is 4 to 8 liters. I'm just trying to hammer home that what goes into the heart should come out through the lungs and back and forth, okay? They're intimately related. So if your cardiac output is down, cardiogenic shock, let's say, you are in cardiogenic shock right now, and your heart's just like, how my heart's normally doing, okay? That is not gonna circulate 5 liters. That's gonna circulate like 2 liters. They're gonna produce less CO2. This is why ROSC, when someone goes from, when we're doing CPR, which is about 20% of their normal cardiac output, they're at like 10 to 20. And all of a sudden when their heart turns on, they double their like CO2 levels, okay? So your CO2 level is intimately related to your cardiac output, which is intimately related to your metabolism. So if you're sick, your septic shock, your cardiac output could be 13 liters. You have to breathe faster. When you're DKA, you have to breathe faster. All these people that are sick have to breathe faster. Does that make any sense? You have to match your cardiac output, has to match your metabolic state. So if my cardiac output's like through the roof, let's say I'm running, I'm gonna produce a ton of CO2 and I'm gonna have to breathe much faster to breathe it off. Any questions? Lots of comments and concerns probably, but any questions? So this is again to emphasize, cardiac output of CPR is 25% of normal. That is why we only need 10 breaths per minute per the AHA guidelines. Even though I'm always panicked, I'm sitting there breathing with them like as they're compressing. Don't do that. So that's why you only need 10 breaths per minute. Questions? Okay. You guys know what PEEP is? It's those little yellow things you buy at the store, right? Yeah. Well, close. What is PEEP? Who wants to tell me what PEEP is? Yeah, what does that mean?
Pressure at the end point of exhalation.
Yeah, it's what's left in your lungs, okay? Positive and expiratory pressure. So, PEEP was invented by the pediatricians. That's why there's a doll up there, okay? They had babies. Babies are kind of dumb. When they come out of the womb, they aspirate their own poop. That's called meconium. And then sometimes they can't breathe on their own. And they just don't do good, okay? So babies need a lot of work. My daughter, when she came out, she didn't even know how to breathe right. She literally inhaled a bunch of her poop. They went in and they suctioned her, and then she had to go on a little bit of CPAP. They call this bubble CPAP. So let's walk through this, how this was invented. So back in the early 1900s, they were just like, oh, I'm sorry, and they tossed your baby to the side. Now, we have magic. We have new stuff. So a German dude in the early 1900s decided to connect oxygen all the way up to the baby's nose. It didn't do anything, okay? Nothing really happened. And he was like, wow, nein. I don't know how to talk German, but he said something like that, and he was angry. And so he decided to try something else. He cut one end of the nasal cannula, and he noticed that babies are obligate nose breathers. He's like, I'm going to shove this air in there, okay? I'm really going to shove this air in there and force it in. So he cranked up the flow meter all the way to the top left, and he shoved the nasal canals in there. And babies have this cool trick. They can breathe and eat at the same time. If you guys try that, you'll die. He basically noticed that they can do that, so he's like, okay, let's keep their mouths open. Who cares? I want to only focus on their nose. I want to shove this oxygen in. And as he was shoving the oxygen in, he decided to get a dirty cup of water, and he put a ruler in it, and he measured little centimeter marks. And he noticed that the deeper he put the actual, like, the end tubing, the more the lungs expanded. So I want you guys, when you go home, try to breathe, well, not at home. One day, when you guys go to a pool, take a hose, put it down at the bottom of the pool, and try to blow out. The deeper you put the hose, the harder it is for you guys to blow out. Okay? So he discovered PEEP at that. He made a reverse bong. So the deeper you put the centimeter marks, the deeper, the more pressure there is to exhale against. And it would expand the baby's lungs. You guys okay with that so far? Anything weird about that? So later on, he realized that they were blowing, well, he didn't, someone else did. They were blowing out the baby's noses with like nosebleeds and everything, so they added a humidifier. And then in about the 60s or so, 50s, we discovered this thing called angiogenesis, and retinal arteries basically grew as there was so much oxygen. So they grew too fast. So they decided to do air oxygen blenders. So instead of giving them 100% oxygen, they would put them down back to what's normal room air? 21%. So this is how PEEP was invented. Any questions on that? And then this is why we use centimeters of water for ventilators. Have you guys ever noticed it's not millimeters of mercury? Because mercury would be toxic. I don't think anyone would have let him put mercury with the babies. Everyone's seen this videos. Like there's 20 million of them online. You guys seen this with PEEP? This is without PEEP. Yeah, that's with PEEP here. Look at that. That's the reverse bong in action right there. Those are some tasty looking lungs. Okay, so since we're in lungs, everywhere else in the body we use millimeters of mercury, except in the lungs. We use centimeters of water, okay? You guys can figure that out why, right? Like mercury fumes, not so good. Okay, cool, so what is a centimeter of water? Well, here it is. 1 centimeter of water is 0.736 millimeters of mercury. And what blows my mind is, are we at sea level here? Pretty close, yeah? So 1 atmosphere, we're at 1 atmosphere, which is sea level, which close enough. 1,033 centimeters of water. How much PEEP are you guys titrating on these ventilators? How many centimeters of water are you guys titrating on a ventilator? Yeah, 5, 10, 20 at the worst case scenario. You'll have a PEEP of 20, okay? We're at 1,033 right now, and we're playing with very small numbers, and you can blow someone's lungs out with very small numbers. It just fascinates me, I don't know. So 1 millimeter mercury is 1.36 centimeters of water. The magic number for the body, I want you guys to memorize this. You guys ever heard of compartment syndrome? Okay, the compartment pressure should always be less than 20. So let's say you guys had a needle and you guys made an A-line setup and you connected it to a needle and you flushed all the water out of it. And you stuck it in my leg right now. The pressure in my leg should be less than 20 millimeters of mercury. What's the esophageal opening pressure? 20. What is my intraocular pressure should be? Less than 20. What should my intracranial pressure, if you guys ever transfer a bolt, I hope you never transfer a bolt, but like if someone has a head injury, what should my intracranial pressure be less than? 20. If I have compartment syndrome, some quack surgeon did a big surgery on me, closed me up, and then said, good luck. What should my intra-bladder pressure be? Less than 20. Everything should be less than 20, okay? That's a magic number for the body. So PEEP should also probably stay around less than 20. Okay, so let's review one, because that was a lot of stuff, and I'm sorry. Stroke volume should be about your predicted body weight, which is 70 mils. I just made that, I picked for me, because I'm myself-centric. Cardiac output is about 5 liters. Tidal volume is 7 mils a kg. Minute ventilation is about, that's alveolar minute ventilation when I wrote 5 liters. Remember, that's different than your actual ventilator minute ventilation. Okay? Type 1 failure is oxygenation, which we control by increasing the oxygen and increasing the PEEP, which we're going to review some more. Type 2 failure is ventilation issues, so respiratory rate plus tidal volume. Your end tidal CO2 and cardiac output are intimately related. What questions do you have so far? That was a lot of stuff, and that was basically 2 days, 3 days of med school in I don't know, 30 minutes, 25 minutes. Are you guys okay? Huh?
Critical strategy, ventilation strategy question.
Sure.
So my approach to PEEP and increasing our low SP2 and increasing PEEP is I increase oxygen birth, FO2 first to saturate the air. But instead of actively pursuing PEEP, I feel like we should maximize the tidal volume, right? And so what I end up doing is I keep a low PEEP and then raise my inspiratory pressures, and my limit is 14 because I'm not trying to stretch it, and then when it collapses, smacks on itself. So I'll march it up, my inspiratory pressure of 14, because that way I'm make sure I'm maximizing the tidal volume, and that's going to be more comfortable for the patient because as you increase PEEP, you intrinsically increase your inspiratory pressure, and so that's going to be uncomfortable for the patient because you are oxygenating them, but you're reverse feeding the nutrition. You're basically giving them suppository.
You're looking way ahead. I love it. No, you're looking right into, this is where we're heading to, basically.
Okay.
How to decide when to increase PEEP and when to increase tidal volume and stuff like that. And it all depends on the disease process. So normal patient, your strategy is awesome. ARDS patient, the
Correct.
other way around. Yeah. So there's going to be nuances. I love where you're thinking. This is exactly where we're going.
Okay, sorry.
No, don't apologize. I want this more. I'm weirded out. You guys are all quiet and sir, yes sir kind of thing. Yeah. Okay. We're exactly going to where you're headed.
Okay.
Yeah. This is an important, very important concept. Like half of the doctors don't understand this concept. Okay. This is a very, very. Do you guys have OptiFlow or high flow on this machine? You do? This is excellent. So this is going to be kind of relevant to you guys. Normal respiratory rate, I'm just going to walk you through just to explain. Flow is just volume over time. That's what flow is, okay? Big volumes over time, big flow. Small volumes, long time, small flow. You guys cool with that? So let's see what a normal flow for a normal adult male is. Normal respiratory rate, I pick 15 because that's easier than 12 or 20. 20 would have been easy, but 20 is a lot. Some people are like, that's not normal, okay? 15 is okay with me, okay? You guys cool with that? Or I could do with the every single medic chart, 16. You guys always do that, right? But that's just hard on math. So if I divide 60 by 15, that gives me a 4-second breath cycle. You guys cool with that? Okay, so 4 seconds of breath. A normal inspiratory time is 1 second in, 2 seconds out, and a pause for a second. So 1 to 3. You guys cool with that? 1 in, 3 out. 1 second in, 3 seconds out. You guys cool for that? Okay, nothing weird, no voodoo math here. Normal tidal volume we said is 500 mils for me, half a liter. You guys cool with that? I'm trying to make the math easy, sorry. So I breathe in half a liter a second. For some reason, the wizened elders of yore decided instead of mils a second, they want liters a minute. That's what minute ventilation is, okay? They want liters a minute for flow. I don't know why. It was before my time. I didn't get a say. But, so let's say half a liter a second. What is that in minutes? We just got to multiply it by 60 seconds. 30 liters a minute. That is your normal flow rate for an adult male. So right now, most of you guys are breathing at 30 liters a minute. 30 liters a minute. So what is OptiFlow, or what is high humidity, high flow nasal cannula? What's your normal nasal cannula go to? 6 liters? Could you crank it up higher? You could. Why don't we? Huh? It sounds like a jet, right? And also basically gives you a cocaine nosebleed. Have you guys it will dry out your mucosa so fast. We don't go to 60 liters. We could go to, you could. I mean, you could, do you guys have the big regulators? And do you guys have big tanks in the truck? You could go to 6. I've done 90 liters a minute, okay? Like if you have a big enough regulator, you can go fast. But if you try it on yourself, it's not fun. So let's go through what these different flow rates mean. Let's play a game. I'm on a 1 liter nasal cannula just because the paramedic student was like, I want to give him oxygen for comfort, which you shouldn't do, okay? I want to give him oxygen for comfort. If he needs oxygen, give him oxygen. If he doesn't need oxygen, don't give him oxygen. But you put me on 1 liter. So I'm breathing 30 liters a minute. 1 liter is 100%. 1 liter is 100%. What's the other 29? 21%, right? The other 29, other 29 liters are 21%. You guys cool with that? They're room air. Nothing weird about that, right? So 1 liter divided by 30 is how much? What is 0.3? Yeah, 3%. Okay, so 1 liter is a 3% out of 30. 1 liter out of 30 is 3%. So every time you give me a liter, you increase my FiO2 by 3%. So if you give me a 1 liter nasal cannula, I'm not at 21 anymore, I'm at 24. You give me 2 liters, that's 6%. I can't do math anymore. But 6, what is that? What's 6 plus 21? 27. Okay? 3 times 3 is 9, right? So if you give me 3 liters, you're giving me 9% extra. Does that make sense how it escalates? So if someone's super hypoxic, you can crank it up. The most we go up to is 6 liter before we start causing damage. Nebulizers go about 6 to 8 liters a minute. We don't care about that little bit of extra flow because there's a little bit of moisture in that, 6 to 8 liters right there. We also have high flow nasal cannulas, and sometimes they they use these in the hospital, and they're supposed to run it with a bubbler, but they don't, and patients have nosebleeds, and they're complaining, and the nurses don't care, but things happen, okay? And then we have non-rebreather masks. Non-rebreathers are only 15 liters a minute, right? Is that correct? 15 liters? Why are we able to get 90% oxygen, 100% oxygen off a non-rebreather? A little reservoir bag, right? So I'm not breathing every freaking second. I'm breathing every 4 seconds or every 3 seconds. And that reservoir bag fills up in the meantime. And I can suck that reservoir bag in and then breathe out. And that's why it can give me more than just 15 liters. I can get the reservoir bag as well. Does that make sense? So this is where they invented high humidity, high flow nasal cannulas. So Optiflow, Vapotherm, Aerogen, there's all these different brands. Your machine, I don't know, they bought it, you said, Stephanie, you guys have it?
It's not humidified though.
It's not humidified? You could. You just need to buy an extra part, okay? And you can run non-humidified air for about 30 minutes and not cause problems, okay? It's not the most comfortable, but you can run it. And at least is it heated? You have the heat, did you guys buy a heated tubing? Oh, that's an extra $1 too. It's like a subscription service here. With Hamilton, they know what they're doing. Seriously, they nickel and dime you. They're like, you want CMV? Well, we'll give you that, but that's going to be like, I don't know, $10 a month. It's more than that. It's way more than that, probably. But they charge you for every little mode on there. So the Optiflow, the best way to run it is using a heated circuit. A heated circuit will heat up the air so your nose doesn't have to do all the work and doesn't dry it out, doesn't freeze your nose up, okay? So sick patients, they run these things in the hospital called Optiflow, Vapotherm, and they run up to 60 liters a minute and completely humidified. So when I'm sick, I'm not breathing 30 liters a minute. When I'm sick, I can be breathing 20 times, 30 times a minute. I can be breathing really fast. Have you guys seen those patients? They're just like DKA and they're super sick. Their flow rates are in the 60 liter range. And so these devices allow you, let me show you what they look like, to go into basically match them liter for their breathing. And your machine should be able to do that. We'll find out today, okay? And then do we have the nasal cannulas for it? Oh, okay. We just paid for the subscription. I like it. Okay.
Just like when you have $5 extra, you can't buy anything good, so you're like, fuck it.
They do that. They'll throw it. They're like, we'll throw this in if you like just pay $50 more. That's it. Yeah. Cool. But these are the devices. They just have a humidifier. That thing right there is like a little rice cooker that you see on the hospital ventilators. It literally just boils the water up right there and makes it hot and nice. That's all. Does this make any sense at all? Flow rates and all that? Or did I lose you guys? Are you guys okay? This is a lot of info, and I'm sorry. So, flow, this is where we start learning about ventilators. Flow is generated by pressure differentials, okay? If I have a high pressure here and a low pressure there, things will move that way. If I create a vacuum here, that creates a low pressure, and that means that pressure over there is higher. Things will move this way, okay? So flow, it depends on pressure. So in this little, I did it on Microsoft Paint, so sorry it sucks. But pressure over there is 35, and pressure over there is 5. You can see that the flow is this way. Are you guys cool with that concept? Okay. So flow also depends on resistance. If you have a lot of resistance, you're going to get no flow. If you have moderate resistance, you're going to get moderate flow. And if you have large or low resistance, large pipes, then you get large flow. Pretty simple. Here's the hardest concept. We're almost there. This is the climax right now. This is where we're like at top. This is the top of the tension thing. This is the hardest graph for medical students to understand. There is something mysterious about it. It's a buffet of physiology, and you don't have to write anything down. This is just a mind experiment, okay? Just for your learning, viewing pleasure. It will not change anything. You don't have to memorize it. If you don't understand it, it's okay. So we said that everything depends on a pressure differential. So to inflate a balloon, we have to create more pressure in my lungs to push the air into the balloon, right? Well, the ventilator has to do the same thing to inflate your lungs. It has to have higher pressure than your lungs. So when a ventilator starts, we're going to look over there. It's at the time 0. Your lungs look like a little crappy balloon, one that I would have blown probably, okay? And then it starts, and it's really hard at the beginning. Have you guys ever tried that at the beginning? It's really, or at least really hard for me. It's really hard for me, and then all of a sudden it gets easier. So the graph climbs up, and then it gets easier, and it gets easier, and it keeps going at a steady rate. I always have to generate a higher pressure in my lungs than the balloon has. Same thing with the ventilator. The ventilator is going to keep driving up pressure because the pressure in your lungs are building up. Are you guys cool with that concept? The pressure is going to keep going up, and let's see if I can get a laser pointer here on this thing. So this is going to keep climbing up until something called the peak pressure. Now, the pressure on this side always has to be higher than the pressure on this side, or there will be no flow. Are you guys cool with that? The pressure on the ventilator side always has to be higher than in lungs, or else air is not going to move. So at every single point across this curve, the pressure in the ventilator is higher than the pressure in the lungs. Well, the crazy thing is there's something called a plateau pressure. If you all of a sudden cut off the flow, cut off all flow, then you can actually measure, and you put a little sensor right here, you can measure the back pressure of the lungs. You can't do that while the ventilator is working because there's air moving around that sensor. So when you pause the breath right here, and there's no more air moving, there's no resistance of the tubing, there's no other things, you get the pressure that's residual in the lungs. Now remember what we said, the pressure in the ventilator, which is the peak pressure, is always higher than the lungs, or else there was no flow. So when you pause the breath, you get this thing called the plateau pressure, and this is one of the most important pressures there is. This is what tells you, should I increase PEEP or not? So did I lose you guys there? That the pressure, the peak pressure, which is the pressure in the ventilator, is always higher than the plateau pressure, which is the pressure in the lungs. I didn't lose anyone there? It's okay, there's no shame in this. This stuff is weird. I didn't learn that. I keep forgetting and learning and forgetting. I probably learned it yesterday again. Are you guys okay with that? So the other pressure that you're going to see here is called PEEP. This is what you guys set on the ventilator. The difference between a plateau pressure and PEEP is called your driving pressure. That's a fancy name, and it's something that doctors might ask you about, a driving pressure. So that's the pressure to inflate the lungs. That is different than the peak. The peak is just the pressure that the ventilator had to generate to inflate your lungs. The plateau is the pressure in the lungs. The driving pressure is the pressure that it took to inflate the lungs. That's what did it take to drive the air into your lungs? You guys cool with that concept? Any weirdness? Cool. So what does it look like on a ventilator? Okay. Well, we can do this thing called the inspiratory pause. Now I'm teaching you guys this. This is not, Hamilton does not have this. I will show you guys how to kind of get this in a getaway. Hamilton does not have this because it's such a small machine. Small machines don't have valves. To stop flow, you need valves. Shut off, opening valves. These are turbine driven. That means there's a fan that's constantly driving, and it ramps up and it ramps down, and ramps up and ramps down, okay? So they don't have valves in these machines, and it's cool. It means less parts, much smaller form factor, but they have a way around that. So, but this is an important concept because it's going to matter when it comes to ARDS patients. But you told me you only transport 2%? So Progress never has any like ARDS patients at Barnes St. Pete's or Progress? 2% of our transport. Yeah. What are you guys intubating? I'm actually curious. Like, is it just drunk dude that just like was passed out?
No. Trauma, stroke, cardiac arrest.
Okay. Trauma, stroke, cardiac arrest. So that gives me a good reference point. So this is a breath hold right here. You pause the breath. That means the valve shut down, and they can actually measure the plateau pressure right there. So do you see the difference between the peak pressure? So this is pressure up here, and this is time. And you have that graph on your ventilators. So this is the x-axis is time. The y-axis right here is pressure. So peak pressure, which is the pressure that the ventilator has to overcome, the tubing, all that fancy equipment in the stack. Maybe you stepped on some of the tubes. Maybe they have asthma. All this pressures that are resistance, that is the peak airway pressure, this guy. And this is the plateau right there. Do you guys see it? They call it plateau because it looks like a plateau. Nothing fancy about it. So this tells you the big difference between the two. The higher the difference between the two, it tells you how much spasm you have in the airways or how much obstruction you have in the airways. Maybe you use a very small tube to intubate them because you were scared. You use a 6.0 or something like that. So that will create a lot of resistance. Any questions, comments, or concerns there? That was a lot of concepts. I'm showing you here different graphs of different plateau pressures during COVID. So this one was not during COVID, I don't think. This was April. Oh, no, it was. Okay, this is a good lung. A plateau pressure of 13 is very small and nice and beautiful. The safety limit of plateau pressure, we found out when they did that big ARDSNet trial that I showed you in the beginning, they found out that the safe plateau pressure is 29 or less, so less than 30. So this was me after tweaking someone for hours during COVID, and I got his lungs perfectly using titrating PEEP and playing with that. So 28. This was just under the safety limits. This was failure. Do you guys see that? Plateau pressure of 40. It's a really high pressure in the lungs, and that causes injury. They found out that patients that have high pressures get injured lungs.